This video is on vertigo. We will examine the main causes of vertigo, look at how to diagnose vertigo, and then how best to manage vertigo. So first, let's clarify the definition. Vertigo is dizzy, but specifically with the room spinning or the world spinning. If it's dizzy without that, it's more likely to be pre-syncope. So there are both peripheral and central causes of vertigo. Peripherally, the most common cause is BPPV, or benign positional paroxysmal vertigo. So this is vertigo that, as the name suggests, is positional. So it may be when they sit up. But importantly, it only lasts a few or maybe 10 seconds and is not ongoing. If the patient says they've been dizzy or vertiginous for hours, it's probably not BPPV. Now, the cause is Meniere's disease, and this is suspected if the patient has tinnitus or deafness. The other main peripheral cause is acute vestibular neuritis, also known as labyrinthitis. Acute vestibular neuritis is likely if it's post an upper respiratory tract infection with no auditory symptoms, so no tinnitus or deafness. The next main cause are central causes, and these are more serious as they're brainstem lesions. Now, it really depends on the exact history as well as the age, but if it's more of an acute thing with vascular risk factors, you'd be suspicious of stroke. If it's a longer time frame, there's constitutional symptoms, they have headache, it may be a tumor in the posterior fossa, or if it's a younger patient with multiple episodes separated in time and space. So different locations, maybe they've had painful blurry vision, maybe they've had difficulty walking, and these are like months apart, then it could be multiple sclerosis. The main examination to diagnose vertigo is using a Hintz exam. So the first part of the Hintz exam is the head impulse test, as shown in this diagram. You rotate the head from one side to another, not all the way, about 30 degrees, and then you're looking for corrective saccade. So normally if you have your head straight, you move it 30 degrees. Then if there's a corrective saccade, it means your eyes move back to look at the position it was initially looking at. And if that happens, it's called abnormal, in which case there's a peripheral cause, which is good. If it's normal, then it's central or it's BPPV. So central, very bad, BPPV, not too bad. Then you want to do an Astagmus. Peripheral lesions are unidirectional and horizontal. If there's an Astagmus vertically and bidirectionally, it's likely to be central. But also, do not confuse this kind of nystagmus with physiological nystagmus. Pathological nystagmus is very obvious. So if you're thinking, is it nystagmus, is it not nystagmus, it's probably physiological and not too much to worry about. Final part of the Hintz exam is test of skew. So you cover one eye, move it, and then you see if there's correction or not. If there's no correction, so the uncovered eye does not move when it's uncovered, then it's a peripheral lesion. If there is correction, it's more likely to be a central lesion. Management, we're going to look at peripheral causes as it's the most characteristic vertiginous presentation. So if it's BPPV, you do an Epley's maneuver to dislodge otoliths from the semicircular canal. And what this entails is essentially bending them over the bed, tilting the head backwards, and then moving it to the side, and you've got to hold it for like 10 to 15 minutes. Meniere's disease, it's an issue with the endolymphatic system, so you want to do fluid restrictions, salt restrictions, avoid alcohol, and in more serious cases you may consider diuresis with thiazide diuretics. Finally, acute vestibular neuritis is normally self-resolving, so you can give supportive treatment. Any antiemetics or danzatron, for example, if they're feeling nauseous. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.